So for both of you, let me ask this question, because clinical practice and trying to fit patients in while doing research or other things can be challenging and hectic. Are you doing PRO data collection in your clinics or offices?
With the foundation, we're doing it all the time.
Okay.
In my clinical practice, a little bit less so. That's the honest answer.
So we have incorporated smart tablets in our waiting room for patients to fill it out. We sometimes have problem consistently giving it to them and getting it to work. We're getting better. But yes, they're helpful to track it over time and to see. This little app that Byron has actually has a real easy to use CAT score. I give it to them often while I'm doing the physical examination, listening to their lungs, and they have to click 8 slots, 0 to 5 question, and you come up with your CAT score. Greater than 10 is a symptomatic patient.
So let me ask you a question. I'll give you a hypothetical based on one of the examples you gave earlier. The guy that could only do 18 holes if he used the cart. He's now feeling well enough that he can do 18 holes again without using the cart, or maybe 9 holes, right? But he's showing improvement. You're not really seeing a lot of difference in his PFT scores. What do you do with him?
Yeah, so it depends whether they're maximized or not. I mean, I think you do the happy dance and say we've actually got a marker that says we've made progress, and this is management of a chronic disease that you don't completely eradicate their symptoms or their physiologic abnormality, but you optimize their quality of life and their function. And so you add therapies if they still have residual deficits until they don't improve anymore. And that's what we try and do.
And you push the need to exercise. I mean,
absolutely.
Now pulmonary rehab is not just exercise. It has breathing techniques. It is a social network. It's one of the issues, Marie, you were talking about doing telemedicine. You know, considering where we are with pulmonary rehab, I think we all agree we need to figure out a way to get that more into the homes. The one concern with that is you lose that social component of pulmonary rehab, which is very important. But pulmonary rehab exercise, really critical issues going forward. Again, it helps the person in many, many different ways. This is, you know, people need to understand, this is almost always a preventable and treatable disease. And we need to do a better job doing those things.
So let me ask you a follow-up to that, which is, where are the differences between how your patients perceive improvement versus when you perceive improvement? And are there significant differences? And I'm going to bring that back to you as well.
It's all about what the patient perceives.
Okay.
I mean, if the patient doesn't feel they're doing well enough, then I need to do more things.
Okay.
You know, it comes back to, again, the concept of goals. And in the app that Frank mentioned before, we've now added, there's a provider component to it, but there's now a patient component to it as well, where they can put in their goals and work towards achieving those goals. But it has much less to do with me than it does with them. If they're not satisfied, then I need to do more. And as Frank can tell you, there are times where there isn't any more we can do. But before we leave this point...
No, I don't want to leave the point. I want to follow up.
So I think it's important to understand, we've talked a lot about medicine, we've talked a lot about exercise programs, but there are a couple of other things just to put on the table.
Yeah, so just to answer, add a little bit to the question you asked, what if you think they're doing better, but the patient says they're not doing better? Often the patient's right, and you're looking at the wrong thing. So if you're looking, well, your FEV1's a bit improved, and it's stabilized, patient says, I don't sense it, I don't feel better. Well, the thing limiting them may not be their lung mechanics at that point. It may be, and then leading into what Byron said, that they're desaturating, or they have pulmonary hypertension, or they have cardiac comorbidity. And so if those are the dominant limiting factors, then improving their lung function a little bit isn't going to make a huge difference. Or if it's the flare-ups, the exacerbations, the day-to-day variability that bothers them the most, and the cough and sputum, that may not be reflected by a little bit of an improvement in lung function.